Welcome. Today we will be talking about history taking and examination in ophthalmology. This topic is very important because this will be the foundation of your interaction with your patients. This is the first things that usually you will do when the patient arrives, and this is going to be the basis of how your patients interact with you later on. The importance of history taking in examination cannot be ignored because good history taking makes easier diagnosis. So some of the history that you will be getting from the patient gives you already a clue of what the diagnosis is. Also, a good history will give you a more focused exam. That means you can spend fewer minutes examining the patient. You can spend a shorter time examining the patient, making the patient more comfortable, because if you spend an hour to do each and every exam that's detailed in the textbooks, your patient will get annoyed, get irritated, and if the problem is an acute problem, then you probably have risked your patient's symptoms getting worse. Also, a good history makes for a more focused lab exams. You have a ton of lab exams that are available in your eye centers or in the hospitals. In particular with ophthalmology, it's more of the eye center exams, and you don't have to give the patient each and every one of those exams. So a good history will make it easier for you to just pick one or two or probably three exams that will strengthen your diagnosis. Don't check all the available exams just because you don't know what you're dealing with, or try to avoid the answer of it's the standard procedure. Try to use your in, your knowledge, your smarts. Try to make it as few exams as possible without compromising your ability to diagnose the patient. Now, it's very important for you to remember that you need to practice good courtesy and good manners. Make the patient comfortable with you. If the patients are annoyed with you, if the patients don't like you, you will find yourself getting answered with one or two phrases whenever you ask a question. For example, when you ask the patient what their complaints are, they'll give you probably one or two words, one or two answers, because they don't really like you. So make yourself as professional looking, as professional acting as possible, and make the patient feel that you actually care. Don't make the patient feel that you're just doing your duty and you really don't care whether they get well or not. The more they think that you care, the better that their answers will be. They'll give you more details. They'll give you more nuances, more explanations on what they feel. They don't just say, "I have a headache" or "I have pain," and then that's it. They'll actually tell you when they feel those problems and what they have been doing to elicit those problems. Also, use simple questions. If you make very convoluted, compounded questions, one questions on top of the other, and not waiting for the patient to answer before you ask the second question, you will confuse both the patient and yourself. If you ask three or four questions in very quick successions and the patient just says yes, you don't know which one they were answering. So try to use simple questions. Wait for the patient to answer before you ask the second question. Don't let your impatience bother your patient or convolute your question and answer portion. Also, try to avoid using jargon. Don't say completely confusing words, especially only doctors will understand. For example, you don't ask the patient, "Do you have epiphora?" You ask if they were been experiencing tears. Are their eyes always wet? Don't ask the patient if they've been having swelling. Ask them for details and convert them into words that they will actually understand. Now, if your patient is talking or more comfortable in a certain dialect, try to get somebody to help you that is conversant with that dialect, because asking a patient a question in English when they're more versed with the local dialects would actually just confuse both you and the patient, because they they will be translating what you're trying to say. So it's best if you ask them at the same dialect that they are very very comfortable with. Get somebody in your group who's more conversant in that dialect to help you or sit down with you, so they could interpret what the patient actually means. Sometimes it's the translation that makes it more confusing. Now, when when you ask the patient for their chief complaint, try as much as possible to use the patient's word. Don't replace them with your words or the way you understand it, because sometimes the patient will say something and translating it into a medical jargon completely removes the nuances that the patient is trying to impart. Also, try to clarify the complaint with the word with the what, when, where, and how. What what do they feel? Where did they feel it? When they felt it? And how? Meaning the exact description of what they're feeling. For example, pain. The patient is telling you they have a headache. What type of headache? Where the headache is? When they were feeling the headaches, and have them describe the headache. Is it pulsating? Is it Does it feel like your head is being crushed? Does it feel like your head is going to explode? And some other helpful descriptions like what were they doing when they were having the headaches. Now, in ophthalmology, you always ask for past ocular history, problems with the eye, because usually they don't include medications that are specific for the eye. They don't include eye drops in their list of medications. They'll tell you their medications for hypertension, for their medications for their diabetes, their medications for infections, but they usually will not tell you that they were using an eye drop, because they think it's not part of their medication regime, unless that medication has been emphasized to be very very important to them, like glaucoma medications. But they will usually skip medications like tear supplements, because they don't think those are meds. They think that those are just supplements. Also ask for any history of surgery or lasers, in particular with the eye. Lasers and surgeries in the eye happen very very fast, usually about 30 minutes, or sometimes in lasers just 2 to 3 minutes, that they usually forget about it until you mention, did they have eye surgery or eye lasers? They will remember their big surgery in their abdomen, the big surgery in their repairs of lacerations, because they're very traumatic. But eye surgeries and laser surgeries are designed to be very very patient friendly. Patients usually forget to mention them. And even if the patient came in without wearing eyeglasses, ask if they are already wearing eyeglasses and how old their current one is. They may have glasses but they are not wearing it. It could be in the bag, they could have left it at home, or the glasses that they're wearing right now could be as far as 10 years ago. We've actually had patients wearing glasses that have been prescribed to them 10 years ago, because they have not consulted a doctor in that period. Also, in the past medical history, these are the list of medical problems that usually are connected with the eyes. Diabetes and hypertension are very notorious in causing problems in the eyes. Rheumatoid arthritis also has problems, especially in uveitis. Asthma and cardiac diseases are important because there are medications that are common in glaucoma that are contraindicated in patients with asthma or cardiac diseases, in particular timolol. It's very, very commonly prescribed because it's the cheapest anti-glaucoma medication. But if your patient has an asthma or cardiac disease in their past, you cannot give these medications. And usually, we will encounter patients with these medications despite having history of asthma or cardiac disease. So it's basically like rolling a dice when this medication can and will trigger their asthma or arrhythmia. Also ask for history of major infections and sometimes even tumors, because or more often than not, these things will find themselves in the eye. As far as family history is concerned, it's very, very important. Usually, we don't pay attention with much to family history in the other departments, but family history is very, very important in ophthalmology. Glaucoma has a very notorious reputation of being passed on to the families. Eye cancer, specifically retinoblastoma, has also been known to be passed on from one generation to the next. Night blindness usually is um, night blindness is usually passed on to families. Genetics is one of the more important reasons for a patient having night blindness. The other would be neuropathy. So if you're patient with night blindness, or even um, um, so if your patient with night blindness has a family history, then the possibility of you being able to remedy it is very, very low. Also, diabetes in the family, as I said, runs very, very rampant in the entire clan. And having diabetes may trigger a lot of reactions in the eye, especially when you're a little older. Look for problems in diabetes in the retina, in the patient's lens, or sometimes as simple as having dry eyes. Now, more often than not, you will get a patient complaining of slight conjunctival irritation or sometimes slight conjunctivitis. You need to be able to distinguish whether the problem is coming from home or coming from work. And having smoking in work or in the family might be the cause of their eye problems, their eye redness. Now, the patient themselves might not be the one smoking, but members of the family where they are exposed to might be smoking. So it's very, very important for you to understand that you will not be able to remedy their allergy or their red eyes because of reaction to smoking if the people around them do not stop smoking, or they cannot keep themselves away from this environment. Also, alcohol and alcohol consumption is very, very important in cases of neuropathy or retinopathies. Patients in certain occupations cannot really avoid um, exposure to smoking or some hazardous chemicals. So you ask where they're working. For example, a patient working in a casino would always be exposed to smoking problems even though they don't smoke themselves. Patients working in industrial areas will have exposure to heavy metals or sometimes even fumes. So taking care of them involves getting them protected from these situations. Also, ask what the home situation is. All of these problems might not be the patient's fault. It could be the problem at home. So, aside from talking to the patient, getting information from the history, let's start now with examining the patient. And the first thing that usually you need to do in all examinations is taking the visual acuity. There is only one exception in checking the patient's visual acuity as the first examination, and that exception is an emergency. For example, chemical burns or CRAO. Now, or well, that's central retinal artery obstruction. So that's the only exception, but in all other patients, you check what the patient can see. Even if the patient comes in with an arrow in the eye, that you still need to see how the eye is working, how much can it see. It's basically both medically prescribed and legal defense for you, because some patients will tell or will complain that your examinations actually made their vision worse. So checking the patient's vision before you examine protects you from these kinds of accusations. Okay, when you check the visual acuity, you only check one eye at a time. Don't check both eyes at the same time, because the vision will always be better when both eyes are working. It will not tell you much. um, it will not really help you in your treatment of the patient. So just one at a time. And when you are in your clinic or in the hospital or in the eye center, you can measure at distance that is really the best. That's 20 feet or 6 meters away. But if you're outside the clinic, you're doing your rounds, you're in the patient's room, you're at the corridor, you're in a mission setting, you measure at near using a near card. It will help you um, determine the distance later, the distance visions later on. And you always check the patient 3 times. Without glasses, if they have glasses, you also check with the glasses and with a pinhole. A pinhole is basically just a cardboard with a small hole in it, or a plastic cover with a small hole in it. The pinhole is basically a physics phenomenon wherein your vision will always get better if you look into a small hole. It rules out problems if it's an error of refraction, if the patient just needs glasses. If the patient just needs glasses, their vision will improve. But if there's an opacity in the cornea, in the lens, or problems in the retina, specifically the macular area, making the patient look through the pinhole will make their vision worse. Ask the patient to cover an eye, like I said, one eye at a time, and read the charts. Now, the chart that you're seeing here is called a tumbling E chart. It's not a tumbling W, it's not a tumbling M, it's a tumbling E. So, ask them where the legs are pointing, to the left, to the right, up or down. This chart is best used for patients who cannot read yet, or patients who are not well versed with the numbers or the letters that you are asking them to read, because usually we use this one. The one on the left is called the Snellen's charts. That's the standard. But there will be cultures wherein they don't recognize these letters. They have their own alphabet. They have their own modes of writing. And oftentimes, they will not be able to understand what these are. So in those cases, use the tumbling E. It will make communication easier. It's also as accurate as what you have. Now, going back to the Snellen chart, the one on the left is Snellen chart. The one on the right is a Hotek chart. The difference is every line in the Hotek chart are 5 letters. The Snellen has different letters, different numbers of letters per line. The first line will have 1, the second will have 2, the third will have 3, so on and so forth. So it makes it difficult for you to determine if the patient can actually read that line or was just able to read some letters and not the others. Okay, the Hotek chart you will be able to see if the patient can read the lines. Now in this case, the line is counted in the patient's favor if they can read at least 3 letters per line. If they can only read 1 or 2, that line is not counted, and then you write the letters, the line on the previous chart. So if it's a 2030 and they can only read two letters on the 2025 chart, on the 2025 line, then you write down their vision, their visual acuity, as 20/30 plus 2. If they can read 3, then you can say, well, the patient can read the 2025 3 letters into 2025 line, so I will write it down in the chart as a 2025 plus 3 because they were not able to read everything. It gives you a more accurate measurement whether the patient is improving in their follow-ups or is deteriorating depending on how many extra letters that they can read after their previous examination. Now, what if they can't read anything on your chart? So you go down through this line. Number one is you do the first one first, and then second, and then third, and so on and so forth until you reach line number 6. First, counting fingers. You ask them to count the number of fingers that you will be holding up. So it's the number of fingers plus the distance. For example, they can count my fingers at the distance of 2 feet. They can also count my fingers at the distance of 3 feet. You always give them the best, which is the furthest distance that they can read that they can count your fingers. So if you raise your hand and they can count the fingers at 3 feet, and they can also count it at 2 feet, but they cannot count it at 4 feet away, then you write down counting fingers at 3 feet. So usually the notes is CF for counting fingers, and you add the distance. If they cannot count your fingers, start waving your hand in front of their eyes and ask them if they can see your hand moving. If they say they can see the hand moving, then you put hand movement or HM. If they cannot, then you move to line number 3, which is light projection. You get your flashlight, you get your pen light, and shine it into their eyes, checking all 4 quadrants: superior, temporal, nasal, and the inferior quadrants, and ask them, can you see my light? They will say yes. If they say yes, ask them, can you tell me where the light is coming from? If they say it's coming from up when you were pointing it at the superior area, or they can say that it's on the left when you're putting it on the left side, count the number of quadrants that they can count, or they are correct. If they can score 3 or more, then you write it down as good light projection. If they can only count 2 or 1, then you write it down as poor light projection. If they say, I can see the light, but I don't know where it's coming from, then you put light perception. Okay? Good light projection, poor light projection, or light perception, not projection, perception. If your patient tells you, no doctor, I cannot see a light, I cannot see your flashlight, I cannot see anything, everything is black, then you put in no light perception. Now be careful, because when you put in no light perception, the treatment totally changes. You're no longer trying to save a seeing eye, you're just trying to manage a non-seeing eye, a non-functional eye. So the treatment very, very much changes when you're treating an eye that can still see versus an eye that can no longer see. So be careful. Make sure that the patient really cannot see any light. Sometimes they say they can't see anything, but what they're actually saying is everything is blurred. They can actually see, but it's blurred. So make sure that the patient understands that they don't see any light. Also, what will give you a clue, if you shine a light, if you put your flashlight as near as possible to their eye and still they cannot see, then you can say no light perception. Also, ask them to close their eyes and then put the flashlight on top of the eyelids. The eyelids, not the cornea. If they say, sorry doc, I still cannot see anything, I cannot even see light, then you can now say that the patient has no light perception. Be careful, it changes your treatment modality. Now, next would be examining your patient's pupil. It's very simple. Shine a flashlight in your patient's eye and check the pupil size. Is it round? Is it 3 millimeters, 4 millimeters? Is it the same as the left and the right? And you check for reactivity. If are they is the pupil reacting to your flashlight? And then swing the flashlight from left to right and check both pupils, because swinging flashlight test is the only way you will be able to check for relative afferent pupillary defect or the Marcus gun pupil. If you don't swing the flashlight, you will miss this very very important sign. Check the patient's eye. Now with the light, check the size, check the shape. Is it still round? Is it differently shaped? And compare it with the left and the right. Now, once you've seen both eyes, try to swing the flashlight so you can establish if the patient has a Marcus gun or not. After checking the pupils, let's check the muscles. You always check this EOMs, means extraocular muscles. Let's check for the 6 cardinal positions of gaze. You will use cover and uncover to check for heterotropias, and use alternate cover test to test for the total amount of the deviation. Okay, so how do you check the extraocular muscles? Patient's eyes, you ask them to follow your finger, the tip of your finger, not your entire hand, just the tip of your finger. Now, you always have that, so ask them to follow it. If you're talking with to a toddler or child, sometimes replacing their target with a small colorful toy helps. Don't use a bell or something that squeaks, because that means the patient will be following your target with their ears and not your hands. Okay, make sure it's a small object if you want to replace your fingers with a toy. Now, you do the broad H test. Don't swing your hands wildly like Zorro in front of the patient. Do the broad H test. That means up and down on the left, swing right in front of the patient, and then up and down on the right. It doesn't matter whether you're testing the left or the right. Just make sure you're testing both. And while you're doing this, you're looking at your patient's eye. When your patient is looking at the tip, both eyes will be looking on that direction, and then you're checking your patient's eyes if they can follow your fingers. So this is how you're testing it. On the upper left, on the temporal side, you are actually checking the the inferior oblique. On the topmost, on the topmost, that's the superior rectus. The left, the one towards the ears will be the lateral rectus, and lower would be the superior oblique. The inferior rectus, the medial rectus, and the superior rectus comprise the ones in the middle. Now, how does this chart help you? If you're pointing your hand up and the patient is looking towards that side, both eyes should be able to look at that area. So the left, if they're looking here, if you're looking at the inferior oblique on your left, then that eye is working on the inferior oblique, and the other eye is using the superior oblique. If it's on the opposite side, the same thing. The side looking towards the ear would be looking at upper ear, would be looking at the inferior oblique, using the inferior oblique, and the ones looking on the other side will be using the superior oblique. Now, also very important, these are controlled by your cranial nerves. Cranial nerve 3 controls most of this. Cranial nerve 6 controls the lateral rectus, and cranial nerve 4 controls the superior oblique. So if your patient cannot look into that direction, you know which cranial nerve is affected and which muscle is affected. Remember, 6 and 4 are the only difference. The only difference, there's only one direction that is controlled by your sixth nerve, and there's also only one direction that is controlled by your fourth nerve. The rest are controlled by your third nerve. Now, going to the intraocular pressure, I need you to remember that the Goldmann applanation is the gold standard in checking the intraocular pressure. So your eye has its own pressure, not just blood pressure, it has its own intraocular pressure. And the Goldmann is the oldest, but it is also the gold standard for this. Now, when you're outside the clinic, you cannot use a Goldmann applanation because it needs to be mounted on a slit lamp. I'll show you a picture of that later. If you're outside the clinic, use something that's portable. A tonopen or a short tonometer would be more practical because they're very handy, and you can perform this examination even if your patient is not sitting down. Now, if your patient has a ruptured eye, do not touch the eye. Do not put anything on top of the eye, even if you're just trying to check the intraocular pressure. Now, this one is a Goldmann tonometer. The Goldmann tonometer requires you to anesthetize the patient's eye because you will be touching it. And the picture below is showing you what you are actually seeing in the slit lamp. What you need to do is align the inner lip of the upper ring with the inner lip of the lower ring. Once those tip touches, the inner lip and the outer lip touches, that is the patient's eye pressure. Okay, moving the dial will actually show that these circles will be moving. This is basically a prism, and this is the gold standard for intraocular pressure. Unfortunately, you can only do this when the patient is either standing up or sitting down, never when the patient is lying down, and you need to attach this to a slit lamp. Now, this one is a manual tonometer. This one is a digital Goldmann tonometer, but it gives you a digital reading which appears to be a little more accurate than the others. And this is a shot tonometer. It's a metal device that you put on top of your patient's eye. The patient needs to be lying down or sitting up with their head tilted way upwards. It looks like this, and you measure the small what you measure is the needle going to indent depending on how hard the eye is. This is an indentation type of tonometer. The Goldmann is an applanation type tonometer, meaning it flattens the eye, and the indentation tonometer indents the eye. The harder the eye, the more difficult it will be to flatten or to indent the eye. But most eye centers will have this version. This is a puff tonometer. It's an indentation type of tonometer. What happens is it gives your patient a puff of air, and what they will feel is that their eyes got hit by a puff of air, and the machine will now measure the indentation of the eye and gives you a measured reading of the intraocular pressure. Now, this is also an accurate measuring device, except it's not as accurate as the Goldmann in the lower or the upper range of the pressures. Now, this is a rebound tonometer. Basically, the probe that you see in front of the eye, the white probe, is going to be bounced on top of the eye, and the machine measures the strength of the rebound. Now, this has been rated that this has been developed so that you can either use it in your clinic, or the patient will have their own version that they can use when they go home. Now, it's more of a consumer type of device. The probe, the white part that is bounced on top of the eye, is replaceable. It's actually consumable, so you replace it after every use, and it's it's designed in such a way that your eye doesn't need to be anesthetized. Your eye doesn't feel pain when this small probe rebounds on the eye. Next, we test the visual fields. You don't need a $1 million device just to be able to measure the visual fields. You can use your own fingers and your eye to do the confrontation technique, which is a good preliminary test. It is not as accurate as the uh, automated perimeters, and each eye is tested monocularly because the both of our eyes are designed to overlap in our vision, usually in the nasal area. So you're not sure if the patient who's saying that they're both of their eyes they don't have any problems is actually just compensating for the other eye. You ask the patient to sit in an equal distance from you, and then your right eye to the patient's right eye, your left eye to the patient's left eye, and you ask the patient to cover one of their eyes. Now, using their eyes, you ask them to focus on your eye, and in between of you, you actually ask the patient to count your fingers. You ask, do they see this? Do they see this? Now, try to ask them to count how many fingers you are trying to show. It will test them whether they can see on the peripheral areas. You test the upper left, upper right, lower left, and lower right. Basically, the quadrants. It will give you an idea if the patient still has very good peripheral vision, because peripheral vision cannot be measured with the visual acuity test. It will only measure the central part. The peripheral part is usually best measured with a perimeter, or in this case, a rough estimate would be on a confrontation exam. This is an old Goldman perimeter. So it's the patient will be tested, and the dome is actually testing the visual acuity of the fields of the patient. That black probe on top will project a light, and the patient will push a button whenever they see that light being projected onto the screen. Now, this is a more modern automated perimeter. The automated perimeter will do the examinations even if the tester is not there. So your staff or the technician could be somewhere else while the exam is being done. Everything is automated and the machine performs the examination for you. This is the result of a perimeter exam. So in this case, you notice that one half of the left eye is no longer seeing. The central part is still intact. However, parts of the periphery has already been compromised. In this case, the black part of the field are the fields that have very, very poor or absent vision already. Now we go to external examination. External examination, that is looking at your patient's eye grossly. You can use a flashlight. You can use a magnifying glass if you want to see it in more detail. But let's tackle it from the outside going in. Now, check the patient's eyelids. Do you see ptosis? It's best if you can measure the margin to reflex distance, meaning the margin of your eyelids towards the reflex of the light. If you ask them to look at their flashlight, they will have a small pinpoint light in the middle of their pupil, and you measure that pinpoint light against the upper margin of the eyelids. That will give you an idea of how high or how low the patient's eyelids are. So whether you have ptosis or not. Do you have lagophthalmos? Do you see unusual growths or lesion on the patient's eyelids? Do you see any bumps there? Do you see anything growing? Now, I want you to also palpate the lymph nodes and the temporal artery. The lymph nodes that are very important in your case is the one in front of the one in front of the ears, the preauriculars, the ones behind the ears, and the ones under the jawline or the submandibulars. Those are the lymph nodes that usually uh, get um, get larger whenever there is an infection or problem along the area of either the eye or the eyelids. Also, I want you to palpate the temporal artery. It's the artery at the temples. In patients with temporal arteritis, it's going to be very large and swollen, such that if you touch it, it's going to be very painful. Usually, the patients will have headaches in that area. Also, if your patient has proptosis or enophthalmos, meaning the patient's eyes are either bulging out or getting sunken deep inside, you use an exophthalmometer to measure either how high it has been sinking inside our orbit or how high it has been proptosing or going out of the orbit. Now, if and when your patients tell you that they have problems with diplopia or you detect any neuro symptoms, it's really best if you can do a full cranial nerve examinations, all 12 of those. You probably still remember them. Now, in order to isolate what actually is affected, try to measure to test all 12 cranial nerves. The problem the problem usually is, if there's a cranial nerve that's affected, the other cranial nerves above or below it might also be affected. And whether they are normal or not, it will actually help you narrow down what the problems are. So again, you're looking at the patient's eye, going from outside, going inward, so you don't miss anything. You look at the eyelids. You're looking at the lashes. Is it normal? Do you have infections? Do you have blepharitis, like we showed you in the symptoms lecture? Going in, then what can you see in the cornea? What you can see in the conjunctiva and the sclera, all going inside, so you don't miss anything. Also, it's really best if you can be able to describe the eye by knowing what the landmarks are. For example, where's the pupil? Where's the iris? The limbus is the connection where the sclera, or the white part of your eye, connects with the dark part of your eye, or your cornea. You have to understand which one is the medial and which one is the temporal side. The medial is the one going to the nose, and the temporal side is going to the ear. So the temporal side of the left eye is totally opposite the temporal side of the right eye. Because now you know the landmarks, you will be able to describe properly in your charts or to somebody else what you actually saw. For example, in this case, you will be able to describe, well, there's a foreign body. I see a foreign body in my patient's eye, and it's in the temporal side of the cornea, about 1 millimeter away from the limbus. Then the patient, your co-doctor, or whether you input it in the chart, whether they see the patient or not, they have an idea what you are describing. So they don't keep looking everywhere and trying to re-examine the patient just because they're trying to find out where the original problem was. Now, usually, we want a more detailed examination of the patient. In this case, we use a slit lamp to do the examination. A slit lamp is also called a biomicroscope because it's actually a microscope that's oriented perpendicularly. So instead of being pointed down like most microscopes, it's pointed towards your patient, and it has an adjustable light. You can either increase the light, decrease the light, turn it into a slit, or turn it into a small dot. Now, the best way to examine a patient under a slit lamp is to go from outside going inside. Let's start from the outside. Usually, the outermost would be the lashes and the eyelids. So, do you see the normal anatomy? Do you see normal contours? Is there any bulging that you don't notice? And do you see any lesions? Anything out of the ordinary should be flagged down and written in the chart. The best way for you to find out whether something is normal or not is to see a lot of normal patients, such that any small bumps that are misplaced, you actually have an idea just because you've seen so many normal patients. Also, look at the conjunctiva and the sclera. Is it white? Is it quiet? Are there injections? Are there lesions? Normally, This should be at least white or just some blood vessels visible. If you see very large blood vessels, that would be already pathologic. If you see any bumps in the area, usually it's already pathologic. Is the cornea clear? That's the front part of the eye. It needs to be very clear. Any opacity in the area is pathologic. So if you see a cornea and there's any opacity whatsoever, it's pathologic. You're looking at the front part of the cornea, the epithelium. Do you see any disruptions? Is there any cuts there? Is there any bumps or any injuries that you see? Do you see any opacities in the stroma, which is the middle part of the cornea? And do you see anything behind the cornea? Is there at the back part of the cornea, do you see anything um, attached to that area? Do you see anything uh, pigmented in the area? So any any areas in the cornea that is not clear is pathologic. Now we're looking behind the cornea and we're looking into the anterior chamber. That's what's between your iris and your cornea. Needs to be clear. It needs to be deep. If it's not deep, if it's very shallow, that's pathologic. You need to note that down. Do you see anything floating there? Do you see anything unusual? If it's not very clear, it's pathologic. Now you're looking for cells and flares, which are actually suspended proteins or white blood cells inside the anterior chamber. If you see this, you need to note it down, how thick it is, or how many of those white dots that you see. We'll show you later on how to grade this in the lectures on uveitis. Also, look at the iris again. Is your pupil round? Do you see any other areas that are thinned out that light is reflecting from it? Do you see any nodules on the iris? Those are pathologics. Now, the lens needs to be clear. Any opacity in the lens is a cataract. Okay, it needs to be very clear. So if there's any opacity, you need to understand that you need to be able to document where it is. Is it in the middle, called the nuclear? Is it at the sides, called the cortical? Or is it at the almost at the capsule or at the very edge, we call subcapsular cataracts. Now, we also need to look into the anterior vitreous. You can usually see that just behind the lens. Do you see anything floating there? Is there any inflammation? Is there any hemorrhage? Do you see pigmented cells in those areas? You need to be able to write down anything that you think is not supposed to be there. The best way is to use a slit lamp because it gives you a magnified view of the patient's eye, gives you a better view. Again, it's a microscope that's oriented towards the patient instead of pointing down. It's a biomicroscope, meaning what you're examining is a living thing. Your patient is alive and you are now examining a living object. Compared with preserved slides that you usually examine when you're dealing with a regular microscope. Now, usually, this will give you enough information because everything's magnified. Now you can see details. You can see a lens that's an intraocular lens that displays some concretions at the back, some fibrosis, all because everything is magnified and now you can see it properly. Now, seeing the eye in magnified view gives you more detail on what you're dealing with. In this case, if you notice, the edge of the pupil is actually attached to the lens. This is because of uveitis. The patient had an inflammation before and this area of the lens, the iris, attached itself to the lens. Now, these details are best seen when the eye is in a magnified view. Next, we go to the back of the eye. You've examined the front part of the eye very, very closely. Now, let's go to the back of the eye. When you're doing your fundoscopy, you need to practice. There is no way around fundoscopy unless you really practice doing your fundoscopy. Now, what you need to do is try to look for the optic nerve. So when you're doing your fundoscopy, when you focus inside, try to look for the optic nerve. But you don't usually see the optic nerve right there and then. You only see the blood vessels first, and then you follow the blood vessels. You know, one part of the blood vessels of the retina will always lead you to the optic nerve. So you follow the blood vessels. One side will always go to the optic nerve, and once you see the optic nerve, try to get the cup disc ratio. You do this um, by estimating how what percentage is in the cup and what percentage is in the rim. Do you see anything unusual? Is there any focal thinning on the rim? Do you see any pallor? Is it still pink? It needs to be pink, or a little orangey. And is it symmetric? Now compare the optic nerve on the right eye with the optic nerve on the left eye. They should almost look the same, but mirror image. Now, from the optic nerve, you go about 2.5 optic disc sizes to the middle. You will see the macula. There's going to be a foveal light reflex in the middle of the macula, and you're also looking if it's clean. Otherwise, if you see some white spots or yellow spots in the area, those are drusens or edemas, or sometimes exudates. Now, follow the blood vessels again and follow the contours. Are they the same size? Are they smaller, larger? Do you see any hemorrhage, any bleeding? Those will be seen as small red dots or small red streaks. And as much as possible, if you can go to the periphery, you're looking for tears, holes, or any thinning on that side. Now, if you're having a difficult time with fundoscopy, try to use your ophthalmoscope more often. Try to put it in the zero, the white zero setting. You look at the eye of your patient, you will be able to at least see the red-orange reflex. That's where you're going to zoom in, and then put it at the red 3. Once you put it at the red 3 and you approach the patient, more or less you'll be able to focus inside. Otherwise, you can click once or twice, just once or twice up or once or twice down from 3. It should give you a very good view of the inside of the eye. If you find yourself doing multiple clicks, you're either too far away from the patient or too near the patient, or sometimes you're just dealing with an opacified lens or opacified cornea, and you really won't be able to see anything behind it. This is what you're going to see when you look into your patient's retina. This is a fundoscopic view. The area in the middle is called the macula, and the disc on the left is called the optic disc. So we call the blood vessels arcades because they're arched around the macula. If you notice, the blood vessels end right about the edge of the macula. The macula will have parts in it. So you have the macula, the bigger part. Then you have the foveola, which is the curved part in the middle, and at the very, very center, which gives you a very bright reflection when you do your fundoscopy. It's called the foveola. The fovea should not have any blood vessels in the area. If you have blood vessels at that area, it's pathologic. Now, this is what you're looking for when you go inside. It gives you a good picture of the eye. Now try to follow the blood vessels and look for this. This is the patient's optic disc. So it's your basic landmark. Everything inside your retina is measured from this area. The the optic disc also has parts. The pink rim, like a donut, the bread of the donut. You remember a donut? You have a small hole in the middle and you have bread outside. The bread part of the donut is called the rim. And the middle part, the hole in the middle where the area is not where the area is that don't have the nerves, is called the cup. Okay, So that's why you have the cup disc ratio. It's very important also for you to understand that the disc border needs to be very clean. It needs to be definite. You need to be able to see it clearly at the disc borders, and later on you also try to check the arteries and the veins. The veins are larger, the arteries are wider. If you don't see the edges clearly, in this case it's very hard to do the cup disc ratio because you really can't understand what's happening at the sides of the optic disc. You can't see the edges, it's indistinct. In this case, if you see something very similar to this, if you see something as bad as this one, you might be dealing with an optic disc edema, or worse, a papilledema. This is an emergency because that means your patient might be having an increased intracranial pressure, not the pressure inside the eye, inside the cranium, the brain. The pressure around the brain might be too high. It's swelling that area. Um, it's creating pressure on parts of the nerves, especially in this case the optic nerve, that it's already become swollen. You notice that there's bleeding around it. The bleeding may or may not be there depending on how severe or how early or how late you have seen the patient. But if you see this, it's an emergency. You need to double check if your patient also have other neurological signs, because this is a sign of increased intracranial pressure. Now, if your patient is lucky enough not to have an increased intracranial pressure, then this must be just a localized inflammation. This is called an optic disc edema. If there is increased intracranial pressure, we call it papilledema. Now, same thing with this one. You can't see the edges. The edges are a little on the blurred side. That's why it's very hard to tell what the cup disc ratio is. Now, compared to the first one, this one is not an emergency. This one is basically drusen's. Drusen's are basically proteins and lipids that are accumulated at the area of the retina, and unfortunately, this is at the area of the optic disc, such that it's blurring the edges. However, compared with the first picture, this is not an emergency. Basically, these are just drusen's at the optic disc. When you're looking around the eye, you will be seeing things like hemorrhages, the red blotch, and cotton wool spots, which are white. Cotton wool spots are unlike the name, they're not actually cotton. They're in areas of ischemia. And hemorrhages are basically broken blood vessels. The shape of the hemorrhages will tell you how deep or how superficial the bleeding is. If it's rounded, like some of this, it's deeper into the retina, and if it's flame shaped, like the ones on the edges, they are more superficial. So it's important because when you see patients like this, you need to be able to to do a back history on the patient. Preferably you did a very good history of the patient, because this one is because of diabetic retinopathy. The patient had diabetes uncontrolled, and it has produced damage in the eye. So you have the bleeding, you have the cotton wool spots, you have the small red dots, and you see hemorrhages all over. Now, it doesn't need to be this bad. It could be just small area with the bleeding and the cotton wool spots, but it would still be diabetes. Now, just because you see a red spot doesn't just mean, oh, it's a hemorrhage and then that's it. You also need to look carefully at the bleeding and look for rot spots. Rot spots are the white the white dot in the middle of a hemorrhage. Rot spots are actually indicative of bacterial endocarditis or some autoimmune diseases like SLE or leukemia. So that's it for now. If you have any questions, don't forget to put it in the comments so we can answer it as soon as possible. So have a great day. Thank you.